In today's video, we have an evidence-based guide to radicular low back pain and our friend, the disc herniation. Let's do it. So low back pain is extremely common in general. Around 80% of the population is going to have low back pain at one point throughout the course of their life, right? It's a big, big, big problem, leading cause of disability worldwide. What about radicular low back pain? Well, radicular low back pain is actually a little less common. It makes up about 3 to 5% of all low back pain cases. However, around 3 to 5% of all folks throughout the course of their life are going to have radicular low back pain. So that's quite a bit. Radicular low back pain and associated disc pathology can be extremely debilitating. It's also very, very scary for patients. They don't know what the heck is going on. All of a sudden, they have this lightning down their leg. It's debilitating. They can't get out of bed. They can't go to work. They may have some weakness. They may have some difference in sensation. It's very scary. From a clinical standpoint, it's different enough from regular low back pain that a lot of students will ask me, is it okay to treat this like normal low back pain? Am I able to weight lift with radicular low back pain and disc pathology? Do I treat this differently than my other cases of low back pain? And I think the short answer is it's pretty similar, but there are some key differences. So today we're going to talk a bit about those. I certainly see a lot of radicular low back pain in my weightlifting folks. So not just Olympic weightlifting, but people like to power lift or just weightlift in the gym that like to squat and like to deadlift. More times than I'd like to hear. I hear a patient comes in, they're deadlifting, they're pulling off the floor. All of a sudden, they have this intense pain in their back. They're kind of crippled. They can't get off the weightlifting platform. They go to the emergency room. Eventually, takes them 20 minutes to hobble out of the gym. Once they get there, get some imaging done. Lo and behold, they have a fresh disc herniation. So is radicular low back pain and disc pathology more common with weightlifting? I don't know that I have the answer to that, but anecdotally, I treat a lot of these, and I think there is a bit of a relationship. The other piece is that if you are trying to get folks back to weight training, we have to know a bit about how to treat these folks, whether or not it's okay to do things like squat and deadlift, so on and so forth. We'll delve a bit into the literature to get some answers there. So we definitely have a lot to go over today. We're going to be going over the prevalence of this injury, the history or clinical presentation. What do your patients say when they come in the door with this issue? What's a prognosis or natural history? Does it get better very quickly? Does it take a long time? How does it kind of pan out? What is the predisposing factors? What are the risk factors for this? Am I more likely to get this if I'm a male, female, age, so on and so forth? What is the anatomy of this? So what does a disc look like? What does that herniation look like? What's going on with the nerve and nerve root? All that stuff. We'll go deep into that. What about diagnosis? When a patient comes through the door, which tests should I do? How about differential diagnosis? What else do I have to be aware of, right? And lastly, how do I treat this? So if you're a coach, clinician, and you want to actually apply some exercise for these folks, which treatments should we try? And the other piece is that if we're not making the progress that we want, what are the other interventions? How about things like injections? How about surgery? And when should we start thinking about this if your patient's not making the progress that you want? And before we really get going, I have an absolutely free cheat sheet for you. So it is an evidence-based guide to radicular low back pain. It's a PDF. It's got a couple pages in it, and it goes over all of the key points of this lesson today. So go ahead and download it. I'll put a link in the show notes in the description and follow along. This is also very useful if 3 months from now you have a patient that walks through the door with radicular low back pain. You're like, man, what the heck did Dan say about X, Y, and Z? Just pull out the cheat sheet. You'll get it, review it, and then you're going to ace your examination with your patient. So let's start this off by asking, what exactly is radicular low back pain? So it is defined as pain evoked from a dorsal root or its ganglion. The most common cause is going to be a disc herniation. And when a disc herniates, and I'm talking about what's called a non-contained herniation, and we'll explain the difference between a contained and non-contained. But when you have a non-contained disc herniation, the inside contents of the disc are shot outside, okay? One of the issues with a disc herniation is they often occur in the posterior or lateral direction. More on this later. But because they occur in this direction, then those contents end up going onto the nerve root itself, right? And just the contact of the inside of the disc, the outside, is a chemical irritant. It can cause a lot of those symptoms that patients experience. So most notably, that terrible pain that goes down the leg, right? The other pieces, there may be an element of mechanical compression. Now, what do I mean by that? So largely when you have a disc herniation, or maybe it's a large bulge, you'll have a part of the disc pressing up against the nerve. So it's not only the chemical irritation of the inside leaking outside, but the compression of the disc material onto the nerve that can give folks a whole bunch of bad symptoms. Radicular low back pain can also have associated radiculopathy. These are a lot of really tough words, but essentially, a radiculopathy is when you have radicular low back pain and there's going to be a neurological deficit. What that means is that there's either some sort of weakness. So you check myotoma weakness and you notice there's some sort of weakness from one side to the other, or some sort of change, usually diminished sensation, one side to the other, or lastly, a change in reflexes. Okay. So if you have any of these neurological deficits with your patient, they have a radiculopathy with radicular low back pain. That's a mouthful. So, what's the prevalence of radicular low back pain with associated disc herniation? Well, it's going to be a lot lower than, let's say, general low back pain or non-specific low back pain, but around 3 to 5% of all folks over the course of life will experience this, and that makes up about 5% of all low back cases. The most susceptible areas to this injury are going to be the L4, L5 disc and the L5S1 disc. Now, don't know exactly why this is, but it is the area with the most motion. About 90% of all disc pathology and radicular low back pain comes from these levels. Unfortunately, the prevalence of hitting the like button and subscribing to the channel is a little lower than I'd like it to be. So, if you hit that like button and subscribe to the channel, it's going to increase the prevalence of knowledge and positive outcomes with your patients. So, I'm sure you've heard that folks tend to have asymptomatic pathology in their spine over the course of time, starting at a very young age. But if you haven't heard, folks will have asymptomatic pathology, so things that don't hurt within their body. You take a whole bunch of people without any sort of low back pain or any history of low back pain, and you do an image, MRI, you're going to find disc degeneration, you're going to find disc height loss, you're going to find disc bulging, protrusions, fissures, facet degeneration, spondylolisthesis. There's a lot of stuff that occurs within our spine. It doesn't actually give us any pain, all right? Now, can this pathology create pain? Of course, it certainly can. However, keep in mind there's a lot of asymptomatic pathology out there. It's one of the reasons why we have to have a clinical examination when we diagnose these injuries, as well as, if needed, an MRI and see if they match. Okay. It's important that we don't just take the MRI and take a word for it because we're not exactly sure if the pathology is related to the patient's pain. I'll read off some of these stats for you. So at 20 years old, 37% of these folks are going to have disc degeneration. At the age of 80, that goes up to 96%. In terms of disc height loss, around 24% of 20-year-olds have disc height loss, and around 84% of 80-year-olds have this. In terms of disc bulges, 30% of 20-year-olds, 84% of 80-year-olds. Disc protrusions, 29% of 20-year-olds, 43% of 80-year-olds. An annular fissure, which is going to be the outer wall of the disc breaking. It is 19% of 20-year-olds, as well as 29% of 80-year-olds. Facet degeneration, arthritis, around 4% in 20-year-olds, 83% in 80-year-olds. And lastly, spondylolisthesis, 3% in 20-year-olds, but 50% in 80-year-olds. So keep this in mind. It's very, very common for patients to have this pathology via MRI and no pain associated with these things. So once we get an MRI in our painful patients, it doesn't mean that that's definitely going to be the reason why they're hurting. However, I think that we just need to keep in mind that pathology does oftentimes correlate with pain. I think right now in the social media world, and this is largely a good thing, we're very positive and we're very hopeful for our patients and just let them know, like, hey, this is an injury. It's definitely serious, although I think you can get better. Look at all these folks that have this pathology. They're absolutely asymptomatic. I think that's oftentimes a good thing for a patient to hear, we don't want to trivialize their pain process. In fact, Burjinski et al. In 2015, they performed a meta-analysis and demonstrated that MRI evidence of disc bulges, degeneration, extrusion, protrusion, and spondylolysis are more prevalent in adults 50 years of age or younger with back pain compared with asymptomatic individuals. So here's the thing. Can you have asymptomatic findings in the spine? Yes. If you have more findings in the spine, does that increase your risk of having pain? Well, based on this study, it does. Okay. So, yes, just keep in mind that when a patient does have a severe injury, right, they have some sort of disc herniation, radicular low back pain, we don't trivialize it and tell them it doesn't matter. And I have a disc bulge too. The other nice thing is that these asymptomatic finding in MRIs don't correlate with a future onset of low back pain. So if you have these things at a younger age, it doesn't mean that your back is a ticking time bomb and at some point it's going to explode because you have facet joint degeneration at the age of 20. So, guys, if you like what you're learning about so far, then I want you to go and check out the Fitness Pain Free mini course. So, I made a mini course that's absolutely free. That's the next logical step if you want to learn more from me. So, in the course, we go over 5 lessons. That first lesson is how traditional schooling has failed us, right? So, schooling is phenomenal from a physical therapy perspective, but doesn't really teach you how to work with high level athletes in the fitness world, right? Doesn't always teach you how to do the lifts appropriately. Doesn't teach you about progressions and regressions of common lifts within the gym. Doesn't teach you how to program normally, how to write rehab programs, or how to write injury prevention programs for these folks. Next thing we go over 7 reasons why people get hurt in the gym, 4 simple steps to getting your clients out of pain, how to build the career of your dreams and earn the respect of your community. It's all well and good if you know exactly how to work with folks within the gym. But if you can't get these folks through the door on a regular basis, then you're simply not going to be living the dream that you want to because you can't get the patients through the door that you want to work with. Okay. So I'll show you how to do that. And lastly, we'll talk a little bit about the fitness pain free certification, right? So I'll leave a link in the show notes. I definitely recommend checking this out. So, what's the prognosis or natural history of radicular low back pain with associated disc herniation? Well, a lot of this information is really good for your patients to hear, but I think the other part is that the evidence is mixed on this, right? So, the first bit of information from some studies, and again, link in the show notes if you want to check out all the references, they're all going to be there, but around 85 to 90% of these cases resolve within 6 to 12 weeks and without substantial medical intervention, right? So, what does this mean? Largely, 6 to 12 weeks, the folks that had that burning, terrible, radicular low back pain that's extremely debilitating as well as scary will get better, right? About 85 to 90% of those folks. And that's amazing, right? Because people are super freaked out by what's going on. The large majority of them are going to get better very quickly, right? The other piece is that you can use this information to help patients know when they're going to start feeling better. The majority of folks really start feeling better somewhere between 6 weeks and 12 weeks, right? However, like I said, this evidence is a bit mixed. So, Constantino et al. In 2017 showed that only 55% of people with back related leg pain had a resolution of symptoms at the 1 year mark. So, despite some research showing that these things tend to go away pretty rapidly, we also have some additional information that shows that some folks, the pain sticks around, and that's unfortunate, as well as a weakness. And I would say that's consistent with what I see clinically. It's not like everyone gets better. We don't have to worry about it. There's definitely a chunk of folks that have long-standing issues, both pain, weakness, sensory stuff. They'll say, hey, my kneecap has been numb for the past 3 years. That does happen in some folks, right? So we don't want to trivialize, again, what the patient's coming in with diagnosis wise, but we do want to give them hope and let them know, like, hey, this gets better just like anything else. The other piece to keep in mind is if someone has a large disc herniation, and really the larger the herniation, your body is better and better at shrinking it, right? So if you have a very small herniation or small bulge, your body might not have to shrink it whatsoever. If you have a really large bulge or herniation, then your body's a lot better at taking care of it. So over the course of time, especially the larger the herniation is, the more your body will shrink that. But here's the other kind of cool and interesting thing, right? So the majority of folks over the course of time, their symptoms will resolve, okay? And oftentimes spontaneously, meaning that you don't have to do anything whatsoever. They just get better over the course of time, right? But for a lot of folks, they don't have any resorption of their herniation or bulge. So what that means is that if they have an injury, let's say day 1, they have an injury, day 2, they get an MRI, up L4, L5 disc herniation. It's this big, right? And then 12 weeks later, my back feels amazing. They do another MRI. Oh, it looks like the disc bulge or herniation is exactly the same size. Well, that can happen, and that's not a problem. But do keep in mind that some folks will have some resorption, but other ones won't. But that doesn't mean your symptoms won't go away, okay? More on this later. So, what are some predisposing risk factors for radicular low back pain? Well, the first one is just going to be age. So you saw those stats before. The older you are, the more likely you are to have some degeneration of the spine and associated disc-related pathology. You'll find men in their 40s or so will start to have more disc pathology, where women, it's more in their 50s and 60s. Gender is also a risk factor, with men being more common at a 2-to-1 ratio, male to female. Lastly, occupation is going to play a role. So, at least women in physically demanding careers are more likely to have a disc herniation and associated radicular symptoms. This study was in the military population. So, let's go over some anatomy of a disc herniation and associated radicular pain. So, I have a spine right here. This is going to be L1, L2, L3, L4, L5, right? And between each vertebrae, I'm going to have a disc, okay? On the outside wall of the disc, this is known as the annular wall. In the case of a disc bulge or herniation, what you'll find is that the annular wall will weaken and sometimes end up tearing. And you can have what you see right here, a disc herniation. Okay. Now, you can have a contained or a non contained disc herniation. So, a non contained disc herniation means that the annular wall has completely disrupted, it's broken free, right? What happens is that the inside contents are now free to leak to the outside. If you have an uncontained bulge or disc herniation, you don't have the inside contents leaking outside. It's only non contained disc herniations and bulges. So here's the thing, the majority of disc herniations occur in a posterior lateral direction. And all that means is that it's on the back and side of the disc. This is probably because this is the thinnest part of the disc. So if you have tears in the annular wall, and there's a bunch of different layers, we'll show you that in a minute. If you get all the way to the outside edge and that disrupts, now you have a non-contained disc herniation and the inside contents leak outside. Now, if you look at the posterior lateral side, right, of the disc, what's really, really close to that? That's a nerve root right here. So what ends up happening is that the inside contents leak outside and they form a chemical irritant because they're right next to the nerve. And that leads to a whole bunch of terrible symptoms in your patients. The other piece is that this bulge right here can push up against the nerve. And this mechanical compression, which kind of crowds the intervertebral space right here where that nerve lives, can give you some symptoms as well. The other thing that I want you to keep in mind, and this is something that's helpful that I tell my patients. So if you look at where the nerve exits, the intervertebral foramen, there's a ton of space, right? So the exiting nerve root only takes up about 1/3 of the total space in that area. So if I have a disc herniation, disc bulge, if it's kind of poking into that nerve, it doesn't mean that there's not enough space in there, right? There's a ton of space. So you can have a pretty large disc bulge or disc herniation, have absolutely no symptoms, right? And also, in those folks are kind of freaked out that have those follow-up MRIs, and they still have some bulging in that area, you just let them know, like, hey, there's plenty of space in there. You don't have to worry about it. Your back is not painful right now, and I don't think you're going to have a crazy flare-up just because you don't think there's enough space in there. The next really important piece of anatomy is going to be knowing how to hit the like button. So if I look at my phone right here, we have my favorite channel. It's Fitness Pain Free. I just go over here and I hit that like just like that. So easy, all right? But a huge part identifying the right anatomy in your patients with radicular low back pain. So here's another image of the spine from the side. And I like this image because you can really see the intervertebral foramen very well. You can visualize the disc, right? The disc is called the annulus fibrosus right here. And that's the annular wall, right, that I was talking about. There's actually several rings or layers within the annulus fibrosus. And if you have a fissure of all the layers into the outside and opens up, you can have what we were talking about before, which is going to be the inside contents leaking outside, right? The inside contents is known as the nucleus pulposus, right? You can also see the vertebral body really, really well above the disc and below the disc. And like I said, immediately behind that disc, that space you have right there, the intervertebral foramen, that's where the nerves come out, right? And keep in mind, those nerves only make up about 1/3 of the total space. So even if you do have a pretty large disc herniation, doesn't always mean you're going to have a ton of symptoms, right? So right here, we've cut the spine in half, and you can appreciate a couple additional pieces that we're going to talk about a little bit later in our presentation. So for one, you see the disc, right? That's the intervertebral disc right in the middle. You can really see those lines or rings really well. So you can kind of appreciate that you have to break through a lot of different layers until you get to the outside layer. The other piece is that the roof of the disc is known as a superior end plate. So it's kind of the bottom of the vertebrae above. And then you have the inferior end plate, which is going to be the roof of the vertebrae below. And sometimes you have what's called a vertebral end plate fracture. So the end plate will fracture and the disc will go up into the vertebrae above it. And that's actually a relatively common injury in the studies we'll talk about later. So, most of the research by Stu McGill, when he was compressing and flexing pig spines, one of the common injuries he found was an end plate fracture, and the disc would go straight up. Right. And the reason why we need to know this anatomy is because we have to know whether or not we can strengthen these structures over the course of time, both before injury and after injury. The other piece I want you to look at and visualize a little bit is going to be the facet joint. Okay. So the facet joint is going to lie right behind the vertebrae. And in folks that have a decent amount of arthritis, they can have some thickening of that joint. And you can notice if you get enough thickening, it does reduce the intervertebral foramen. And in folks that end up having a lot of disc pathology and go on to get a discectomy, sometimes they'll remove a little bit of the bone in that area along with the disc material just to give a little bit more space. So now that you have some evidence-based information about radicular low back pain, you still need to know how to treat these folks. Well, I have a case study for you where I break down a patient with radicular low back pain, show the exact treatments that I use, and show exactly how he got back to weight training over the course of time. I'm going to leave a link up here. You should go ahead and click on that and continue with the learning. Lastly, I just want to say thank you so much for your support. You truly allow me to do what I love for a living. If you're watching this on YouTube, please hit that thumbs up button. If you leave a comment, it helps the algorithm. I'd also love to know your thoughts on this presentation today. Please subscribe to the channel. It helps me out tremendously. If you're listening to the podcast version of this, please consider leaving me a positive review. Again, it helps tremendously. If you want to see more content like this in the future, we got to make sure we grow this over the course of time, right? And lastly, if you want to support me even further, consider subscribing to Fitness Pain Free Insiders. This is going to be my premium subscription membership to Fitness Pain Free, where all my best content updated monthly lives. So head to fitnesspainfree.com, click on the programs link, click on Fitness Pain Free Insiders online library, just $1 for a week trial. I'll also leave a link in the show notes in the description. All right, go ahead and check it out. And lastly, I have all of my references, and it's a god awful amount of references. I know you can't read any of this. So if you really want to check out the references that I use, I recommend checking out the show notes, link in description, and you can see all the references that I use. And if you like them and you want to comment on them, leave a comment.